All right, so welcome everyone. Thank you for joining us today. My name is Sarah Webster. I'm Knowledge Broker for Niagara Connects, and we also have Sarah Johnson from our team on today acting as chairperson in our online meeting room. Today we'll be hearing from three presenters, Kelly Falconer from the Canadian Mental Health Association Niagara branch, and then Jenny Stranges and Despina Tazimis from Quest Community Health Center. And they'll be talking about the integrated community lead model of care and how that enhances service navigation for clients in Niagara with complex needs. So if this is the first time that you're joining us on a Niagara Connects webinar, obviously the audio is coming through the phone line, and I do hope you've also clicked the web link to join us in the online meeting room. All of our participant lines are muted during the presentation, and this allows us to cut down on any background noise, but also allow those who are joining in groups to have any type of sidebar discussion or conversation that you'd like to have. We do record all of our webinars, and a link to the recording will be posted on the Niagara Knowledge Exchange, probably later today actually, and we'll send out a link to you with a link to an email to you with a link to the recording, a PDF of the slides, and other resources that you'll hear about today. We'll send that communication out to you within the next week. Please do use the chat pod down the left-hand side of your screen. If you have any questions or comments during the presentation, we'll certainly queue those up and save time for a little bit of a discussion at the end of the call, and we'll bring those forward then. So I'll turn it over now to our presenters to take us away.
So good morning, everybody. This is Jenny Stranges from Quest talking. So we're going to talk a little bit about the ICL model, and you're going to find it's a format that's not that new or innovative. It's just a very concrete format that we're trying to standardize and promote. So you're going to find that a lot of it that we're talking about today is stuff that you already do in your day-to-day work, but this is just an agreed-upon format that has all the pieces so that it becomes predictable and standardized. I'm going to start off talking about the fact that we have no conflict of interest to disclose in this presentation. And start out just talking briefly about our organizations respectively. So I'll speak on behalf of Quest. So Quest is a community health center located in St. Catharines. We're an interdisciplinary primary health care team made up of nurses, nurse practitioners, outreach workers, social workers, dietitians, community health workers, client coordinators, a variety of healthcare professionals. Our focus is on general health care as well as health promotion and prevention. We focus on healthcare through the lens of the social determinants of health, and our services are for specific priority populations, including individuals who are homeless, at risk of homelessness, mental health addictions, as well as isolated seniors, sexually and gender diverse populations, children and youth and families in poverty, individuals who frequent the ER for their care, as well as migrant workers. So a wide variety of populations who experience traditionally barriers in accessing mainstream healthcare. We provide individual as well as group programs and services, and again, focusing on health promotion and community capacity building, including in addition to primary health care. We have 16 points of service across the Niagara region, trying to create accessibility for people. And we're a community governed organization governed by a board of directors that's reflective of the community. I'll leave it to Kelly to talk a little bit about CMHA.
Hi, so Canadian Mental Health Association services the entire Niagara region. So we have offices in St. Catharines, Niagara Falls, Welland, and Fort Erie. We focus a lot on education, training, advocacy, and direct client service. When it comes to education, that would be many presentations in the community regarding mental health, mental illness. We do mental health first aid training, different types of presentations are offered depending on the need. We also have, we do advocacy, anywhere from individual advocacy to group advocacy related to mental health. For direct client service, we have crisis programs, so that would include our Safe Bed program, our Mobile Crisis Rapid Response program, our Urgent Support Services program. We also have intake and referral where people can just walk in and talk to someone and determine what services might be appropriate for them. We have a walk-in counseling in Niagara Falls from 11:30 to 7 on Wednesdays, and in Fort Erie from 11:30 to 7 on Thursdays. And we have support within housing, so we have many housing units across Niagara that are offered to individuals who have a history of mental health, and they also have homelessness. We have a transitional housing program that is concurrent disorder based in St. Catharines for females. We have one in Niagara Falls that's a program that we service individuals co-occurring brain injury and mental health. So it is in partnership with Brain Injury Reentry, Community Reentry Program. And we have community support workers all across Niagara that work with individuals in their own homes in the community to help support them with whatever areas they might want support around. And we have an employment program as well that offers employment readiness as well as help to obtain employment. We have specialized groups available as well, such as illness management and recovery, dialectical behavior therapy, and moral recognition therapy, which is our newest program for individuals involved in the justice system. So now I will move forward to talk about our objectives for today. There we go. Sorry, had trouble switching the slide. I just wanted, today we're going to be talking about the Integrated Community Lead Model, which we call the ICL model, and the benefits of that model, how it works. We're going to discuss some case studies of where we've used it and how you can take part if you're interested. And at the end there will be a little bit of time for some questions if you have any questions. We do have a question though to start, and the question is, have you ever participated in a care planning meeting involving 3 or more agencies? If you could answer that question, and just be interesting to find out, as in terms of the participants today, how many people have been involved in such a care planning meeting in the past. So from the looks of the poll, majority of individuals have been involved in the past in a care planning meeting, so that's great because you'll find that that we're talking about similar things in this discussion. You may have experienced these type of meetings before. Okay, so here we go. So now I'm just going to talk to you a little bit about what the ICL model is, or the Integrated Community Lead Model. It's an approach to care where one person leads or navigates the health and social service system with the client. This is done in collaboration with agencies, healthcare providers, and other support individuals. It's a model that's already been adopted by Behaviour Supports Ontario and HealthLinks with a lot of success. This is definitely not something that we have developed. This is something that we are jumping on board with because we believe it's best practice in serving all the individuals that we see come through our doors, and how we can help individuals provide the most service for them. So some of the benefits of using this type of model are that all services are communicating and collaborating together on one plan of care with the client. So the client is the center of that care and an active participant. not sure if you may have been involved with meetings before in the past. Sometimes clients have been a participant at that meeting, and maybe they have not. This definitely involves the client being a full participant. It would be the one person leading, and there would be and communicating with the client, and many other service providers involved, or family supports or other supports that would be involved in that in developing that plan of care. Other benefits are the client has that one main contact person. So there's clear communication, no mixed messages. It reduces that stress and that confusion for the client and the system. And it increases the chances of follow through on the plan. It works with the client to prioritize needs. The model focuses on the social determinants of health. It ensures both the client and the system know who is a part of the care team. So a lot of times what we've found in the past when working with individuals is people aren't always aware of all the people involved in their care or their service, especially if they have complex needs and they have multiple service providers involved. It's very difficult sometimes for people to be able to keep track of that. Who's who and who do they work for and what do they do and who do I go to for what? It can be quite confusing to navigate our system, and so this model helps the individual to navigate that. It offers a holistic integrated care approach. So you're not just looking at one area of need, you're looking at all different areas of their life. Whatever the client wants to focus on, it's very client directed. So whatever they would like to focus on, whatever needs they want to address from different areas of their life, that's what this is intended to do. It eliminates the duplication of services. So in the past, I know I've been involved in situations where we've been working with an individual and they've had other service providers involved, and we found out that either a couple of us were working potentially on the same thing, and sometimes even in a different manner, or the other thing could be happening is you're assuming the other community agency might be working on something when they're not, or they're assuming that you're working on that. So then that area actually doesn't get addressed at all. So this eliminates that from happening. It ensures the plan is documented, regularly updated, and communicated so everybody knows what's happening. The client knows what's going on, and all the other service providers involved also know what's going on. It builds strong working connections among the care team and the agencies. So you're all working together for the benefit of the client. So now I'm going to switch it over to Jenny, who's going to walk us through the ICL model.
So we're going to just talk a little bit about the details of it, sort of how we identify who may benefit from the program, what's involved in taking the lead, as well as identifying how to create a plan of care and evaluate. So all the different steps. I'm going to get into them a little bit more in detail. So let's start with identify. So we start off by looking at which clients would benefit from bringing supports together and coordinating a plan. We're not talking about doing this for every single client we see. We're thinking for some agencies, I know for here at Quest, it's probably about 30 or 40% of our agencies, of our clients who, they have complex care needs. They're individuals who are high risk for crisis, and those that often have multiple service providers involved, or maybe they don't and they need multiple service providers involved. So typically, those that we're not tracking with, right? We don't see the progress that we'd like to be seeing. They're not achieving their goals. Things aren't moving forward. Those are the ones that really would, we feel, benefit from involvement in the model. And when it comes to taking a lead, it often starts with initiating, calling together a support team and starting to coordinate the community planning meeting. So you want to start off very clearly with obtaining client consent to communicate. We need to have documented consent so that we can talk to the other people involved or potentially to be involved in their care. Then determine who's already involved, start doing a sort of a scan of who's already involved in the client's care. and who may need to be based on the client's needs. So oftentimes comes from asking the clients, who they're connected to, but also what's going on for them, what matters to them that isn't being met. So it could be around, as for us, where they're healthcare provider, but they may have food security issues. They may have a need for housing. So thinking about who those partners are that can really focus on those components. Next step is to coordinate a community planning meeting, and that's just the basics, right? The who, when, where, and putting an agenda together. It's really important to get those details concretely identified so we know when we're going to have the meeting, where we're going to host the meeting, and to give people a clear idea of what will be discussed at that meeting before the meeting. Then we want to assess the resources needed in order to host the meeting. Is there some people who will need to call in? So do we need a conference calling system or unit? Are some people comfortable participating via OTN, the Ontario Telenetwork, so video conferencing them in? And that takes a little setup and time as well. We want to ensure that we prepare all the appropriate background. So their previous medical records, any assessments that were conducted, their hospitalization records, all of those kind of pieces may be included in the background information that we pull together. Then you want to actually facilitate the meeting. So all the pieces that go with that. We need someone who's a clear lead who will ensure, for example, simple things like one person speaking at a time, that the communication or conversation stays on topic, stays solution focused, and that we manage the time, right? Most of us have really busy schedules. So we want to make sure that the time that we pull together for this meeting is used efficiently. So setting, along with the agenda, maybe some time frames. And ensure that whatever is discussed is recorded in the plan. Those are the pieces of the actual taking the lead. Let's talk a little bit now about the plan of care itself. So the plan of care outlines everyone's responsibility, including the client. From my experience, this is the piece sometimes that falls apart in other planning meetings, is that we don't have a clearly documented plan of care with responsibility centers. You want to determine what everyone's doing currently for that client, what's working and what's not. There's no sense in continuing down a path when we know that the client's not happy with the direction it's going in or it's just not working. The other piece with the plan of care is you want to identify what needs are not being met and who can assist with those particular unmet needs. Sometimes that's about asking agencies to step outside their mandate and to stretch a little bit. So if we don't have someone who's taking on a certain particular need and it doesn't fall in anybody's bailiwick around the table, can someone do it anyways? Third, you want to work with the client and the team to establish those smart client-centered plan of care. So specific, measurable, agreed upon, realistic, time-based. Ensuring that, basically setting the plan up for success. Next, you want to outline and record everybody's responsibilities and accountabilities, including the clients, with timelines for implementation and reporting back. So important. So if you have X that you're going to do for this client, X will be done by when, how will you report back that X is done, and that feedback loop for if X isn't accomplishable. Sometimes agencies take on things with good intentions, but then it falls apart and they're no longer able to follow up on it. That happens, that's life, but we need to report back to the table so someone else can pick up on that piece of the puzzle. Next, you want to make sure that you provide a copy of the plan of care to all parties, especially the client. It's their plan. They need a clearly laid out plan for them, something that's written in clean, clear language that they can understand and comprehend, and that they can share with whoever they'd like to as well. And lastly, you want to ensure any changes to the plan are updated and communicated to everybody by the lead. So the lead's role is really pretty dynamic. It's both in setting up the meeting, facilitating the meeting, but then doing all the follow-up afterwards to ensure the plan is updated, that's communicated, and that everybody's on the same page. The best laid plans sometimes that go awry because changes occur, time frames change, and no one's aware of it. And so people think maybe it's going really well, and they don't understand that we need to redirect, or B, people aren't aware that there is a need that's already been met, and they continue working on meeting that need, and it wastes time. So getting that clear communicated plan of care is critical. That leads us to the next point, and that's evaluate how the plan is going. So how does the client feel the plan is working? That's always a really good starting point, right? If the plan is working very effectively, the client will sense that. Things will start to fall in place for them. They'll have a few unmet needs start being met. There'll be some sign for the client. Another good indicator if the plan is working is does the client continue to be in crisis? We could have a great plan, but if the client's still running from crisis to crisis to crisis, perhaps our plan needs to be readjusted. Third, is the client frequenting the hospital? And this is not for things that they maybe should, but for issues best managed elsewhere. It may be an evaluation that the plan needs some tweaking. Next is if the client's firmly connected to long-term supports. Evaluating that connection is important. It's about an active referral, not simply making a referral and hoping they connect, but making that referral, following up with the client to ensure that they've connected, ensuring that the connection is working and that it's a good, strong working relationship. Sometimes I always say that connecting individuals to different agencies is like finding the right pair of shoes. Sometimes the first couple pair of shoes you try on, even though they're great shoes, they don't work for that person. They need to move on and find another pair of shoes, but we need to make sure that they get a good pair of shoes. Next, does the lead role need to change based on the best fit as the plan progresses? So, for example, USAT, our Urgent Service Access Team at Quest, we're often the ICL for a lot of clients that we come into contact with. That makes great sense. We start pulling a plan together. We'll take the lead. But as they connect to more long-term ongoing plans, it might make more sense for example, Gateway to take the lead on with this particular client because now they have a case manager for Gateway. They found residential services with Gateway. So Gateway is going to take on the integrated community lead role, and USAT then steps back as a member of the role, not the lead. So it's a flexible role, but we need someone definitely engaged and identified as the lead. The lead role is reassessing the plan of care as needed with the client and the community partners, and it may involve holding additional meetings with partners, reviewing the plan of care with the client to determine if any changes are necessary, or identifying the need for a safety or crisis plan if required, especially if the client continues to be in crisis. So if we look at the plan again, it's about identifying the clients with complex needs, taking the lead, planning, solidifying the plan of care, and then evaluating the plan of care. Let's say a little bit more about taking the lead because I think this is probably the most complex piece about this. And the first thing is identifying yourself as a lead, who, how, and when. The lead can be a person who's involved with the client, just somebody who's already involved in the treatment plan of the client. It can also be the person with the best rapport with the client, someone that the client trusts, someone that the client understands their role and function, has developed a good working relationship with. But thirdly, it could be just the first person who identifies the need for coordination. So if you're involved in the client's care and you notice that the plan isn't going forward, it keeps floundering, and we need to, that there is need for more communication, then you may be the ICL because you're the one who identified the need for the ICL. So what are the lead's roles and responsibilities? First, ensuring consents for release of information are maintained and updated as required. It's very important to this whole process. And you always want to keep in mind that consent can be withdrawn at any time. So we have to both keep consent, but also make sure it's maintained and changes are made as per the client's wishes. Next, the lead role needs to direct and communicate with the client regarding any necessary changes to the plan of care. This is important to this model. The notion is having one voice, a consistent voice, a trusted voice, and reducing miscommunication by having multiple people talking to the client about the plan of care. Next, you need to follow up with the client and review the plan of care on a regular basis. So to make sure that as the ICL, you're in constant communication with the client, that they're aware of the plan, that they're aware of any changes to the plan, and that they're still on board. Another role for the ICL is to communicate any changes with other agencies. Updating everybody regularly. Changes occur, especially as things start to get active for a client and you start to get a meeting together. Changes to the plan and adjustments and tweaks happen pretty rapidly at first. And so you need to make sure you keep everybody updated on a regular basis. The last part is of the roles and responsibilities for the ICL is developing a crisis plan or a safety plan as appropriate, and ensuring that the plan is distributed to coast and PERT as needed, in addition to communicating with other agencies involved in the plan of care that there is a safety plan in place and that this is what the plan is. So let's take a look at sort of where we're at as far as how comfortable people are in participating in the ICL model. I'll just ask you to chime in on the poll here as far as how comfortable you are in participating in the ICL community planning model. Very comfortable, comfortable, somewhat comfortable, not very comfortable, or maybe you wouldn't even return the phone call. And keeping in mind, for a lot of you, this is work that we're already doing. We're just agreeing to sort of standardize it, make it more and more consistent across the board. Okay. So we see most people are coming in at pretty comfortable, fairly comfortable. Yeah, that's good. Good to see. Excellent. So, and again, we see a lot of those planning tables in this community, so it's not surprising that most people feel fairly comfortable in doing that. I'm going to just go back to the second question, which is, how comfortable are you now in taking the lead? So most people are comfortable in participating. What about actually taking the lead? Very comfortable, comfortable, somewhat comfortable, or not comfortable at all? I'm starting to see the results come in. People mostly comfortable or somewhat comfortable. Few people not very comfortable. We have one person who's very comfortable. Excellent. You just want to be aware that if you're not very comfortable in taking that lead role, you may want to think about what kind of training or support you need to increase your comfort level. But also you might want to think about, as an agency, have those conversations that if you don't have a lot of that skill amongst your team as far as comfort level of taking the lead, is there another model that you can use? For example, having a few key people who act as the ICL for the entire agency. So we see, yeah, people are in the mid-range, they're comfortable, somewhat comfortable, a little bit on the not comfortable side. So something to start thinking about for sure. We're going to also look at, again, part of the beauty of this model is that there is a templated plan of care, and we're going to just review it. Despina's going to talk to you a little bit about the templated plan of care.
Hello, everybody. This is Despina with Quest Community Health Center. Before we go into our case examples, I just want to review a tool for the community to use. The tool is developed to actually help streamline the ICL process, especially in our integrated community meetings. A lot of times ideas are generated, people are taking on roles, but this template sort of helps document the plan and everybody's commitment and really sets those SMART goals that Jenny was previously talking about in one documented place. So what you'll see on the plan of care template is that you would put the date of the meeting, put a unique identifier for the client. You would put the ICL lead's name and contact information right on the top, and it'd be great to also put the attendees of the meeting on the top of the template. At the bottom you'll see there'll be a completed by, so who actually completed this care plan and the date completed. The columns you see are goals. So these are client-generated goals. As you know, if the goals aren't made with the client, oftentimes they won't be successful. So these are the client-generated goals. The plan, so how are we going to achieve the goals, but the broad strokes. And then the action really identifies who is going to do what to help achieve the plan. And these action points are not only the care providers and the family, but it's also the client's actions as well. The next column is the person and agency responsible for the actions. And then the last column is the timeline. So it really helps sort of set a time frame when these goals will be achieved. So next, I will just go through one case example that was led by the USAT Urgent Service Access Team at Quest Community Health Center, and there's a little picture of the team up there. So this is a plan of care for one client that we had a community meeting with. So this client is a young male individual with mental health and addictions needs, frequented the emergency department for those needs. And when this client was identified, USAT took the lead in sort of starting the ICL process. So there was a community meeting that was held at the hospital where the client was at the time, and involved in this community meeting was the client, his family, NHS social work. The client identified that he had a worker with CASIN, and the CASIN worker came to the meeting as well, and also the USAT team. So at this meeting, we generated goals with the clients, which are outlined in this plan of care, the plan, the actions for each of those plans, and the agency taking the lead and the timeline. So I'm just going to give you one example of one of the goals that were generated. So one of the goals was sort of continuous primary health care. So the plan was to connect the client with Quest Community Health Center for primary health care. So the action was the USAT team would connect the client and sort of help build the rapport with the physician and the care team here at Quest. The client could come for appointments every 2 weeks to sort of get the client on track with medications and other health needs. And the client was also invited to groups at Quest Community Health Center, for example, Skills to Cope. But at the time, the client's not ready, but we have it on the care plan, so when the client is ready, he knows that this is an option for him. So this is similar with the other goals that were generated for the client. And one of the other things that we highlighted for the client and with the client is who are the client's support teams. So we outlined everybody that's involved with the client, how this client can connect with the supports, and sort of the most appropriate time to connect with the care team, just so that the client is aware of who he can turn to for support, and as well as everybody on the care team also knowing who's involved in the client's care. So now I'm going to pass it on to Kelly, who will take us through an example with CMHA.
Thanks, Despina. So our example from Canadian Mental Health Association involved an individual who was contacting 911 quite regularly, almost nightly, and our mobile crisis rapid response team was often responding. What was discovered in the process was the individual really just wanted to talk to someone, really wanted some supports, and often did not need to go to hospital or need to actually have any type of police involvement. So in the process, we decided to link the individual with a community support worker through Canadian Mental Health Association, and to through that process, the community support worker was then able to identify who was already involved. She paid a visit to the client. Our mobile team worker went with her to introduce her and provide that warm transfer. And she was then able to speak with the client about who was already involved, and then actually look at what were some of the reasons why he was calling 911 and what was he looking for, what kinds of supports was he not getting from the services that he already had in his plan. So from there, we were able to identify who was involved and who needed to be involved. So a meeting was held with the client, our Canadian Mental Health Association community support worker, one of the mobile workers, and police officers from the team. Bethesda Services, which is a developmental service agency who we have a behavior consultant that works with our SafeBed team. So we invited her to because he was on the wait list for behavior services. So she had identified she would be able to pick him up. So she came to the meeting. The Developmental Services Ontario Agency, which we refer to as DSO, they were able to come to identify what other services within their sector might be available to the client. The Urgent Support Access Team, USAT, that Despina works with, they had a counselor working with the individual, so we had invited the counselor. And the lodging home that the individual was living in, as well as the primary care provider within that lodging home who was providing the client with primary care at the time. So the meeting was held, and we then set some identified with the client what some of their goals were. So just walk through one of those with you as Despina had done. So the first goal was to be able to access crisis services at night. One of the problems we discovered was that the individual was in the lodging home they were at. He did not have a phone, and he had to go into the nurse's station to make a call to Coast. And if the answering machine or voicemail picked up, that he had to then leave the office, and when the Coast program would call back, he was not always able to go into the office to talk to them because the nurses might be busy with someone else in the nurse's station. So he wasn't able to access that phone crisis support and right away when he needed to, when the office was accessible and he was able to access that phone. So we set up a system for him that he would start with Coast, and if he was not able to get a hold of Coast, that he would call the distress center, and then he could also call the Barrett Center as he was thinking about relocating to the Hamilton area. So the Barrett Center is also another crisis service, and they have live answer. So it also made sure that he would be able to get live answer and wouldn't have to leave a message on a voicemail. So that was something he was agreeable to and felt that was going to be able to meet that need. And the other thing along with that was that we looked at whether or not having access to that was going to reduce those 911 calls. And if it was, that we would actually have the Coast team preemptively call him at a specific time that was scheduled with his lodging home so that he could access the phone. So that was one of the goals that we looked at. But there were several goals, as you can see from the plan, and we went through all of them with the client, and there was a specific plan made for each one with action and time frame and those individuals responsible. We would normally, our case example is missing the top part that identifies who attended the meeting. I just did that more for space for the presentation, but it also doesn't identify names, but for the person and agency responsible, well, we would actually identify the name as well there to be more specific and ensure everyone's aware of who's accountable for what actions. And you can also see that the client is accountable with the service providers for many of those actions. So it's very much client-driven and recovery-focused. So next, I want to just talk about implementing the integrated community lead model in Niagara. So this all started with Behavior Supports Ontario bringing this model to Niagara for seniors quite a number of years ago, actually now, and 41 agencies actually signed an agreement to implement this model with seniors back then. It was really picked up by Niagara Region Mental Health, and specifically in their seniors community programs. And I was actually a part of one of those interactions with. I was called to the table to meet in regards to one of their clients that they were using the ICL model with, and this was an individual who had called EMS 58 times in 30 days. And after implementing the ICL model and getting the appropriate services in place at the time they needed to be in place, this was completely eliminated. The client within 30 days was no longer calling EMS at all. It was very, very successful. This model came from the reason why we chose to promote it and move forward with it as best practice is many things have happened since then. We had a system case review that led to a recommendation to implement this type of model. We looked at sort of followed up on a case that many agencies were involved in and reviewed that from the standpoint of how can we improve, and discovered that much of the issues involved agencies working very much in silo and not working together and collaborating in their service to clients. And each agency, there were many agencies that didn't even know other agencies were involved, and that wasn't helpful to the client. So this model definitely addresses that. At the same time, we were looking into, we also did through our Niagara Service Delivery Network at Dual Diagnosis Committee, we had a subcommittee on coordinating case management services that also identified that the integrated community lead model would be the way to go, because many agencies were having difficulties connecting with each other to help to support a client, and that this model addresses that. Since then, Health Links has identified more mental health and addiction related individuals who are actively using emergency services. And in Niagara, they have chosen the integrated community lead model as well as the model of care for individuals who are identified as a Health Links client. So those individuals that are active users of emergency services, the ER, or have high hospitalization rate. And so after some discussions, the Quest Urgent Support Services Access Team decided to pilot the model. So the steering committee for that group, which involved Canadian Mental Health Association, Community Addiction Services Niagara, Niagara Health System, and Quest Community Health Center. So we all signed a memorandum of understanding to implement this model across our programs and services. So we've all done it a little bit differently. I know that some agencies are choosing to identify leads, specific individuals who will be the ICL. In our agency, we're looking at all of our community support workers being able to be integrated community lead, but that we have certain individuals who have been trained in the model and have used the model who will help role model that for the other individuals, and will sit in on some of their individual meetings at the beginning to help people to learn how to coordinate service and be in that lead role. The ICL model has also been incorporated in the Niagara Crisis Protocol launch. So we did a launch about a year and a half ago of the Niagara Crisis Protocol. So this involves all agencies developing what we now refer to as a safety plan. It was in the past referred to as a crisis plan. So we changed the name to safety plan due to we wanted to have it seen as more of a preventer, because that's what we're looking at, preventing the crisis rather than having something for after the crisis. So although it'll help for managing a crisis if it happens, the idea is we're going to try to prevent it from happening in the first place. So the safety plan would be developed by the lead in each agency who's working with that client, and then that would be shared with the COAST team, which is the community outreach team for crisis outreach team for Niagara, that for individuals who actively go into crisis, if the client consents to that model being shared, then whenever they go into crisis, the individuals who will respond to that crisis will know how to respond, because they also work with the Niagara Regional Police, who find it very helpful to know, what are the do's and don'ts in working with this particular individual in crisis. What don't I want to do or say, and what do I want to do or say to prevent the crisis from escalating. So we've been using that with our mobile team, but other officers have been getting on board as well because they have access to the coast crisis plans. The other thing with that is that those plans would be sent to the Psychiatric Emergency Response Team, which is the PERT program at the hospital. So these are the mental health nurses at the hospital that would see the person when they go in for a mental health crisis, and they would have access to that plan. They will now also have access to the plan of care, because the plan of care has been added to the safety plan, so that the hospital, when they come in, will know who's involved in what they're doing if the client consents to sharing of that information. So I'm now going to turn it over to Jenny to talk about some of the considerations for implementation.
So when your agency is thinking about implementing the ICL model, one of the things you want to do to start off is identifying a clear agency protocol for obtaining client consent to share information and to meet about the client. So having a clear process that everybody in your agency understands. Most of you do already, but this is maybe a little different consent than you're used to obtaining, so you might have to tweak your consent forms or your messaging to the client. Next, you want to determine who will participate in the ICL model from your agency. So we talked, I think, a couple times about different models that different agencies are implementing, whether it be everybody who's involved in client care may be in ICL, or you have some agency leads. You also want to ensure that your agency leads understand the process and the need for an organized approach, in addition to being comfortable assuming the leadership process, right? So those facilitation skills, the being able to manage the paperwork and communicate with everybody on a regular basis. It's important that everybody takes that same predictable, organized approach. Next, you want to have an understanding that investing more time up front is more efficient than waiting until a crisis happens. Everybody needs to be on board with that in your agency, so they don't find that the LCL is time-consuming, it takes me away from my work, understanding that it's investment in your work that makes your work more efficient. Along the same lines, next is promoting the need for community-wide uptake and involvement in the ICL model. It's important that we bring on more and more agencies to participate. The more agencies and the more diversity in the type of agencies who participate, the stronger the plans. And following up with that is just promoting your agency or within your agency about signing off on the Memorandum of Understanding. The Memorandum of Understanding is just that. It's an agreement around the purpose, the use. I have an example here, just the template that USAT used, the Urgent Service Access Team used with its project management team, that it just talks about the purpose, the guiding principles. It's just a basic commitment that your agency will participate in the ICL model. And so if you're interested in obtaining a copy or to sign on the MOU, we'd ask you just to contact Kelly or myself if you're interested, and we'll send you out a copy for signature. So when we look at what's next, well, what's in progress currently is that, again, USAT's piloting the model within the project management team within Quest. We're also circulating the MOU throughout the community for sign-off. We're circulating the Toolkit as well, which provides instructions on how to implement the model, including the plan of care and the safety plan template. Again, it's for that predictable, consistent application of the model. We also are offering support as needed to mental health and addiction agencies who are interested in the uptake of the model. We're in the next little while, we'll be presenting at the Mental Health and Addictions Directors Group, again promoting the model, bringing the MOU for sign-off. What's coming up in the future for ICL within our group? One is we're going to evaluate both the uptake and the impact. So as far as uptake, we're looking at how many agencies have signed off on the MOU, the number of ICL meetings that have held throughout the community, so general uptake. As far as impact, looking at those clients who are involved in the ICL process, and measuring things like what's been their crisis and hospitalization rates, what's the client experience of the process, what's their feedback. And we're also investigating for future steps the opportunities to upload the ICL plans into Clinical Connect or the IAR, the Integrated Assessment Record, for ease of access. We're trying to promote sort of some tools or maximize the tools that are already existing in the community so that those plans of care are easily shared within the circle of care, within consent, and easily updated so that we reduce the burden on the individual to have to do those pieces. Kelly, do you want to talk about the benefits?
Hi, sorry. Just to explain from the previous slide, for those who don't work within the Ministry of Health or LIN-funded programs, Clinical Connect and IAR are access to information sort of record systems, repository systems where information is kept for on client files so that it can be accessed in relation to client assessments or plans or recommendations, test results, things like that are all kept on these type of records, and many community mental health organizations are being able to access these type of records now. Just wanted to explain that in case you're not from a LIN-funded organization. So wanted to just, the take-home message from our presentation today in relation to the integrated community lead model is that all services with this model communicate and collaborate together on the client plan of care. So it really is best practice. It's an opportunity for the client to have everyone who supports them working together and sharing that information so that everybody is on the same page and everybody knows what's going on. Also important is that the client is the center of that care and they're an active participant. So this isn't a bunch of agencies getting together to plan something for a client. They're there, they're part of it, and they are identifying what it is they want, and that's what the agencies are all working together on. It really reduces that confusion and that stress on the client to have to know who they're supposed to see when, who does what, who I call for this. The client really would communicate mainly with the one person around their plan of care, and we have found that really makes things a lot more clear for the individual and just streamlines everything for them. The model eliminates that duplication of service and ensures that all of the priority needs are being addressed appropriately. Because we want to make sure that we're not assuming that someone's doing something when they're not, or doing something someone else is already doing, and maybe even in a different way, and creating so much more confusion. So this eliminates that, and it offers a holistic and integrated care approach, which we know is the best type of approach for the individuals we serve. So we really hope that you will, at the very least, take part in our integrated community lead care planning sessions when we give you a call. But if you're interested in actually taking part and being the lead at times when you've identified that a client needs that, you're more than welcome to join on board with the rest of us and sign that memorandum of understanding and move forward in that direction. So we really strongly believe that across Niagara, if everyone was working with individuals from this model of care, that we would be able to provide so much better service for them. So we will be offering after the webinar, you will receive information. I believe it's also going to be available through Niagara Connects on their website, but the Memorandum of Understanding, the ICL Model Toolkit. So there's a whole toolkit on how to use the model, how to be a lead. It has the plan of care in there. It also has the Niagara Safety Plan. And the priority community referral form. We didn't talk a lot about that today, but that's a referral form that you can use as a community agency to complete and send to the psychiatric emergency response team if you're sending someone to the hospital. That identifies why you're sending them to the hospital, what are the things that you're seeing to help them make an appropriate assessment, and the psychiatrist make an appropriate assessment for whether or not the person needs admission to hospital. It's been a very effective form, and we highly suggest that you use it if you do send someone to the hospital. So now I guess we're opening it up to some questions, and I see there's a question on there now already about, is the paperwork forms required for HealthLink's client the same as the ones in the Toolkit and the ICL model? Yes, the model is the same. We are actually using a different plan of care than the HealthLink's model plan of care. The HealthLink's model plan of care is I think it's around 4 or 5 pages long, and it's quite detailed and goes into a lot of medical needs, which we've found that for trying to get the individuals to want to really take on the role of being a lead and to participate in this, that the plan is somewhat complex for our individuals from a mental health and addiction perspective. That it's kind of complex for individuals to complete, especially if they're just starting as a lead, and that we wanted to simplify the process to get them to get more people to want to use it and to buy in and to want to be a lead. And the plan of care that we have chosen is to use really identifies the main things that you want to look at in terms of, like, what are the client goals, what needs to be done, who's going to do it, and in what time frame. And those are the really important things that everyone needs to sort of know. The ICL themselves and the client could actually work on that HealthLink's plan of care if the individual is a HealthLink's client separately with more details. But it's not always necessary to have everyone else involved in their care to have all of that information. We have found anyway, but it's entirely up to agencies what they want to use as their plan of care. We have just chosen to use this particular template because it's much easier for coordinators to use.
I'm just going to put the thank you slide back up there. And certainly, as we've heard from the speakers today, they are open to follow-up questions, or if you're thinking about trying out the ICL model, please be in touch. As I've put in the chat pod there, we will be sending out the recording, and resources will be emailed out within a week, at least, to everyone who registered for this event or the previous one on November 5th. And we'll also post those resources to our website, the Niagara Knowledge Exchange. I've put the link up there as well. So thank you very much for the presenters today for taking the time this morning to do this presentation again, and to all participants who joined us. And when we do close the meeting room, you will be redirected to a short evaluation survey. I think it's just 3 questions, but we really appreciate you taking the time to complete that to make sure that at Niagara Connects we can continue to provide content and material that's most relevant to you. So thank you, everyone.
Thank you, Sarah, and to Niagara Connects for coordinating and putting the presentation together. It's excellent. Thank you for your help.
Yes, thank you very much.
You're welcome. Have a great day, everyone, and we'll be speaking with you soon. Take care.
Great, thank you.